Thanks very much, Adam. That was really interesting. In the patient cases, one of the frustrating cases we see where patients have de novo metastatic disease who've delayed treatment, although I think that some of the younger patients would have had metastatic disease shortly thereafter anyway, because they presented with relatively more aggressive disease. And maybe that's where we're seeing even a greater benefit. It's hard to know with the CDK4/6 inhibitors. The guidelines I think are fairly clear that patients with hormone receptor positive disease should receive hormone therapy in their metastatic setting. But I think patients who present with de novo metastatic disease or bulky disease or visceral disease, a lot of practitioners are still using chemotherapy as a sort of induction. Ian, what's your approach to that?
So I'm always surprised when I hear that, just because in general, the guidelines based on good data are that we should be using hormonal therapy in all patients with ER-positive metastatic disease, except in the cases of visceral crisis or someone who you don't expect to have a good response to endocrine therapy. And a de novo patient is even more likely to have a good response to endocrine therapy. So in this particular patient, her LFTs, even though she had liver disease, her LFTs were normal. She had good estrogen receptor and progesterone receptor expression. I think she's very likely to have a very nice response to the combination of endocrine therapy and a CDK4/6 inhibitor, as Adam suggested. And I would think she's a great candidate for doing that.
Adam mentioned that he would choose an aromatase inhibitor first in this patient population, which is similar to what I choose, just liking an all-oral regimen rather than an injection until we know that there's going to be a difference in this patient population. Is that, Ian, what you do also?
Yeah, I generally use aromatase inhibitors in the first line. Again, maybe there'll be unless there's a study that's, will conclusively show that starting out with fulvestrant is beneficial in the long run. We don't have that as of yet, and aromatase inhibitors are easier to use, don't require injections, and a lot of our other second line studies are built on fulvestrant. So I think it just makes more sense to use an AI and spare the patient the injections, since they're likely to be on it for a very long time.
Yeah, I think that also the combinations in the second line setting really do use fulvestrant, so that's important. Adam, how do you decide what CDK4/6 inhibitor you use in these patients? And is there any difference, for example, in the way you would treat a patient with bone-only disease versus having this limited visceral involvement or even more extensive visceral involvement that's asymptomatic?
Yeah, I mean, let me address the first question that you did before I go to the second. So in terms of patients with visceral disease that occurs after a number of years, fairly slow growing, really ER positive, I think, again, I would not reach for chemo. I think I would very much agree with Ian, that you really need to think about these agents first. And I think after these having been around for 5 years, I think there really is a movement in our community to do that and not reach for chemo first. In terms of which agent, I think there's a lot of kind of going back and forth, people thinking that abemaciclib has better validity, or at least better data in visceral disease. And again, I think a lot of that has to do with the patient selection on the trials and how they're measuring the endpoints. And I'm not so sure that I agree with any of the data that these are much different. I think the biggest difference, again, has to do with the dosage and the toxicity, the diarrhea in one versus the neutropenia in the other two. And so for that reason, I don't have a problem. I generally, since I just use it for the longest period of time, I tend to use palbociclib. But again, I think if there were data that suggested that abemaciclib were better or ribociclib were better, then I would think about changing it. But right now, I tend to reach for palbociclib with the understanding that they're pretty much the same. I really don't have much of a difference in terms of their efficacy.
And do you take the same approach?
Yeah. I mean, there are patients who, have preexisting neutropenia for some reason, who would favor abema in that patient. A patient who had had a brain met that had been treated, I would favor abema. I mean, obviously that doesn't happen very often in this patient population, but it has. So, I mean, there are some, kind of outlier situations where I would favor using abema first over palbo, but for most patients I give palbo. It is interesting, given the COVID-19 situation right now, should we avoid drugs that cause neutropenia in favor of abemaciclib in that situation. Obviously, we don't have any data, but it's something that I think probably should also be considered, depending on how that virus issue is in your area.
I think, one of the other areas, of course, is the premenopausal patient population that you showed. And, the Mona Lisa 7, I think, is a really interesting trial. And so in those patients, I've actually been using a little bit more ribo to try and use all of the agents in all settings, since we don't really know which one to use when.